Can I call upon Anil Poddar, please? Triple antithrombotic treatment in ACS and PCI. Patients how to individualize.
I thank Academy of Cardiology for inviting me for talking on triple antithrombotic therapy in ACS PCI patients and how to individualize. I'm sure at the end of my talk I will leave you equally confused as me. This antithrombotic therapy nomenclature starts with SAPT, which is a single antiplatelet therapy, DAPT, which is a dual antiplatelet therapy, or DAT, which is double antiplatelet therapy, or also called as dual antithrombotic therapy, which consists of one antiplatelet and one oral anticoagulant. And the triple antithrombotic therapy is two antiplatelets and one oral anticoagulant. So the choice of optimal therapy is a challenge as it involves significant increase in the bleeding risk, and the choice of regime depends on balance of risks, that is major bleeding, and benefits, that is reduction in risk of stroke, CV events, or stent thrombosis. The indication for triple antithrombotic therapy in patients with ACS or undergoing PCI is with new atrial fibrillation and who are candidates for anticoagulation, or patients with pre-existing on anticoagulation therapy who had emergency or elective PCI, patients with LV clot, more than mild MS, or patients with mechanical heart valves. The drugs which are used for triple antithrombotic therapy are aspirin, clopidogrel, and ticagrelor, which are antiplatelet agents, rivaroxaban, dabigatran, apixaban, which are NOACs, and warfarin as VK or vitamin K antagonist. The bleeding risk and the thrombotic risk, this has to be balanced when we are looking at triple antiplatelet therapy or antithrombotic therapy. The bleeding risk involves, these are the patients who are age of more than 75 years, renal disease, liver disease, active cancer, or patients who have anemia, low platelet count, patients with stroke, bleeding diathesis, prior bleeding or transfusion patients, so patients on OAC or NSAIDs, or who have recent trauma or surgery. There is a Hasbled score which involves the same factors, and it is scored from 0 to 5, 5 being highest risk and where we have to consider alternative to anticoagulation. So bleeding events prevention with triple therapy checklist involves, before PCI you have to calculate the thrombotic risk, you have to calculate the bleeding risk score, adopt to OAC, and avoid GP2B3A as far as possible. During PCI you have to go for radial access or smaller sheath use, and after PCI you have to use a tailored use of antithrombotic treatment and duration. The Danish study showed that the incidence of major bleeding in 100 patient years was 2.6 with single antiplatelet, 3.8 with double antiplatelet, 4.7 with double antithrombotic therapy, whereas with triple it was 10. So we have to avoid triple antiplatelet or antithrombotic therapy as far as possible. The ischemic risk is calculated as ACS at clinical presentation, prior MI, peripheral arterial disease, heart failure, prior stent thrombosis, CKD, multivessel disease, or patients with 3 stents or 3 vessels, or bifurcation stenting or left main stenting. Now when we are deciding about triple antithrombotic therapy, we have to have a balance between the ischemic risk and the bleeding risk. Ischemic risk we have seen all the factors just now, bleeding risk also we have seen. So if the ischemic risk is more, it favors the triple antiplatelet therapy or triple antithrombotic therapy. If the bleeding risk is more, it favors the dual antithrombotic therapy. So we have to have a chart of thrombotic risk and bleeding risk, high, moderate, low in both the arms, and it has to be a moving target. With each visit you have to see how the patient is behaving and accordingly adopt to the therapy. West trial was one of the trials which utilized clopidogrel and VKA versus VKA, clopidogrel, and aspirin, and you can see that in the triple therapy arm there was a high bleeding. This was a simplification of reference trial which was attempted by aspirin withdrawal. Rationale for withdrawing aspirin was that the risk of bleeding is highest in the first month following PCI. This trial included 69% of patients with AF and 28 ACS. There was 64% relative decrease in bleeding episodes, and the ischemic events were also decreased. But there was a prolongation of 1 year in 1 year triple antithrombotic therapy. That has been questioned, and now it has become shorter. West trial showed early discontinuation of aspirin reduced bleeding without any apparent increase in ischemic events, and this led to multiple trials which with aspirin-free trials. Pioneer AF was another trial which involved 3 groups. One was rivaroxaban 15 mg daily with P2Y12 inhibitor for 12 months. Another was rivaroxaban 2.5 mg BD with ASA and P2 Y12 inhibitor for 1, 6 or 12 months. And group 3 was warfarin with ASA and P2 Y12 inhibitor for 1, 6 or 12 months. And you can see increased bleeding in triple therapy. But at variance with was trial, the patients were stratified by intent in duration was not for 1 year, but it was reduced to 1 month or 6 months or 12 months, and only 22% were on triple therapy. The rivaroxaban based regime resulted in reduced risk of total bleeding events and recurrent hospitalization, and there was no difference in MACE, but the power for it was low. The redevel PCI utilized dabigatran in 150 mg or 110 mg with VK and aspirin in other arms. 2,700 patients were studied, and due to design of both Pioneer AF and redevel PCI, they could not distinguish whether the reduction in bleeding was attributed to use of DOAX or VKA or avoidance of aspirin or both. The Augustus trial involved apixaban and VKA along with ASA in 2 arms, and you can see again with triple antitherapy involving aspirin had a higher bleeding risk. So in patients with atrial fibrillation and recent acute coronary syndrome, PCI treated with P2Y12 inhibitor antithrombotic regime that included apixaban without aspirin resulted in less bleeding and fewer hospitalizations without significant difference in the incidence of ischemic events that included vitamin K antagonist or aspirin or both. When you look at all the trials of dual versus triple antiplatelet therapy, the one common thing which you will find that the dual therapy is associated with significant reduction in bleeding with no increase in thrombosis. This was a common thread which we involved in all the trials. So if there is a patient with AF and ACS undergone PCI, then you can give triple therapy for short period of time. But if there is no PCI, you can just go for dual antithrombotic therapy. Guidelines are based on this, and the ESC guidelines suggest that 1 month or 1 week of triple therapy and convert it to dual antithrombotic therapy as early as possible. ACC guidelines have given some guidance about using clopidogrel in preference to prasugrel, double therapy with P2Y12 inhibitor, that is clopidogrel or ticagrelor with vitamin K antagonist is reasonable to reduce risk of bleeding compared to triple therapy, and double therapy with clopidogrel rivaroxaban is again preferable to triple therapy. With clopidogrel dabigatran 150 mg is again preferable to triple therapy. So as far as possible, triple therapy should be avoided or should be shortened. This is a message between all these guidelines now. Post-discharge, all of them go for oral anticoagulation after 1 year, but for 6 months they are on dual antiplatelet or dual antithrombotic therapy in stable patients, or with ACS it goes for 1 year. This is a busy slide, but a patient who has a new diagnosis of atrial fibrillation and who is on antiplatelet therapy, there are, if the patient is requiring oral anticoagulant therapy, if the patient is on antiplatelet therapy, then if it is for primary prevention, then you can just stop and go for oral anticoagulation. If the patient has stable ischemic heart disease, and if the patient has gone angioplasty less than 6 months, then you can continue, or below 12 months, you can continue antiplatelet therapy for 1 year, preferably clopidogrel, and then again after 1 year you can just go for oral anticoagulation and stopping all antiplatelet therapy. Again, history of ACS, if there is history of ACS, if it is less than 12 months PCI involved in less than 12 months, then you can go for again dual antiplatelet therapy with clopidogrel, and then you can just go for anticoagulation after 1 year and stop all the antiplatelet therapy. If the patient has undergone some carotid stenting or some intervention for peripheral arterial disease, then you can go for up to 1 to 3 months clopidogrel, and then you can just convert it to oral anticoagulation. This slide shows about thromboembolism, venous thromboembolism, and being considered for PCI. So they are already on oral anticoagulation. If you can stop oral anticoagulation, then they can go for only antiplatelet therapy. But if oral anticoagulation has to be continued, if it is an elective PCI, you can wait for the PCI and stop oral anticoagulation and then do PCI. But if you cannot stop, then you can go for PCI and use the same therapy which is used in all other patients. Now, in consists, when you see the recommendation of triple antiplatelet therapy or antithrombotic therapy, you can see that there are North American perspective and European perspective, and there is slight difference. In North American perspective, the default approach is clopidogrel for 1 week, and aspirin is for 1 week. Clopidogrel is for 1 year in high ischemic risk and default approach. But in high bleeding risk, clopidogrel is only for 6 months. That is the only difference. Whereas in European perspective, the ischemic, if the ischemic risk is high, then aspirin can be continued up to 1 to 6 months. That is the difference. So antiplatelet drugs, clopidogrel is a drug of choice. Prasugrel should not be used. Ticagrelor may be considered in patients with known poor response to clopidogrel. Or if you have to continue after 12 months, then you can use it. Ticagrelor, there is a trial with ticagrelor 90 mg BD for 1 year, 60 mg BD for 1 year for high thrombotic risk patients. And for easy remembering, 90 and 60, the Pegasus trial, which TME54 is a trial. I will say that there is a need for trial with ticagrelor 60 mg BD with NOAC for 6 months to 1 year in patients with high thrombotic risk, because many of us are not comfortable with clopidogrel only as a drug after PCI. The current paradigm is that, in summary, the current paradigm is that triple antiplatelet therapy should be as short as possible or even avoided based on individual ischemic and bleeding risk profile. We should be constantly on a lookout for converting into double thrombotic therapy. Ongoing treatment with triple antithrombotic therapy is a moving target, and ischemic risk and bleeding risk should be constantly evaluated with each visit. Triple antithrombotic therapy should be guided by the guidelines, however, should be executed as per the clinical judgment. Thank you.